Riwaj Bhagat. Good morning, everyone. I'm Dr. Riwaj Bhagat, the PGY-4 Neurology resident from the University of Louisville Hospitals. I'll be pursuing my Vascular Neurology Fellowship at Boston University from the July 2021. I'm presenting a grand round on the topic, Saving Penumbra, a multidimensional approach. First of all, I want to express my utmost gratitude to the Department of Neurology, Dr. Remo, Dr. Palade, Dr. Lu, who has been my mentor since the first year, and entire faculty members for training and trimming me to be a neurologist. I do not have any disclosures for today's grand round. The objectives of my presentation for today we'll be reviewing about the cellular and molecular mechanism of the stroke and penumbra. I'll review about the ideal imaging option to detect an ischemic penumbra. I'll be reviewing on the multiple measures to save the ischemic penumbra, and I'll spend most of my time on these multiple measures. And finally, we'll be discussing about the future of acute stroke treatment. This is the basic module and the multiple dimensional approach that I'm talking about that I'll be discussing broadly on the topic of reperfusion, neuroprotection, blood pressure management, and metabolic management in the acute stroke treatment. Let's start with ischemic penumbra. What is penumbra? Penumbra was been coined from the Latin word pines and umbra, that means almost and shadow respectively. It was first termed in 1981 by Dr. Astrup. Penumbra means a viable tissue around the irreversibly damaged ischemic core after the focal ischemic occlusion of the cerebral artery. Penumbra is functionally impaired but potentially salvageable, and this is a quest for the acute stroke treatment. Let's understand the penumbra based upon the focal ischemic brain model. What happens if our cerebral blood flow gets occluded? As we can see in the figure number A, after the focal cerebral artery occlusion, different layers of the ischemic region has been hypothesized to be formed. Region 1 is a normal, well-perfused brain area. Region 2 is a polygamic area. Now, region 3 is a penumbra, and region 4 is irreversibly damaged ischemic core. So this penumbra is being further defined with the various parameters like cerebral perfusion pressure, cerebral blood flow, cerebral blood volume, mean transit time, oxygen extraction fraction, and central metabolic rate of the oxygen. Let's see, based upon these parameters, how the penumbra can be hypothesized. After the focal cerebral occlusion, there will be a decline in the cerebral blood flow, as we can see over here. As there will be a decline in the cerebral blood flow, cerebral autoregulatory capacity will vasodilate and increase the cerebral blood volume. The brain will abstract the maximum oxygen as much as possible to survive, and the central metabolic rate of the oxygen remains stable. This happens in an oligamic area. If the cerebral blood flow further declines, this autoregulatory capacity gets disrupted. The cerebral blood volume starts decreasing. The brain cannot extract any further oxygen. It has reached its maximum capacities. And that is a time when a central metabolic rate of the oxygen starts declining, and we'll start seeing a functional impairment in the patient. If the cerebral blood flow further declines, there will be a time where the autoregulatory capacity is totally collapsed and the central metabolic rate of the oxygen further declines to the extent that brain cannot function at all. So this region, area number 3, that has been defined as decrease in cerebral perfusion pressure, decrease in cerebral blood flow, and decrease in central metabolic rate of the oxygen, is hypothesized to be the penumbra. So what is an ideal or a critical cerebral blood flow that defines the penumbra? As we can see in the figure number A, which shows the measurement of the cerebral blood flow, ATP, lactate level, and the EEG changes as per the before the occlusion, during the occlusion, and after the occlusion of the cerebral artery. Over here, I'm pointing towards the 25% decrement in the cerebral blood flow from the basal rate of cerebral blood flow. There will be a decrement in the ATP production, and there will be an increment in the lactate in the brain up to the 4-folds within the 3 hours. We can see there is a focal slowing in the brain. So the reperfusion has been reestablished. The brain restart producing the ATP and the lactate level declines, and we can see the increased cerebral activity in the brain. So this area is being hypothesized to be a penumbra, and with the evidence of the EEG is being objectified that this is a reversible damage. This part of the brain can be saved. Likewise, in the figure B, which shows the cerebral tissue perfusion or cerebral blood flow and intracellular pH of the brain cells. As we can see over here, when the cerebral perfusion flow or the cerebral blood flow is normal, the normal pH of the brain has been maintained, that is 7.01. But after the decrement or the severe occlusion of the cerebral blood flow, as has been shown in the solid lines, there will be a decline in the pH of the cerebral neurons. It reaches to the point where the cerebral blood flow is critical at 10 to 12 cc per 100 gram per minute, and the pH of the brain ranges around like 6.5. That is a time when brain is permanently damaged. The histological slides of this area of the brain tissues shows 100% damage of the neurons. As we can see in this dotted line, the blood flow is not completely occluded. There is a partial occlusion, and the cerebral blood flow reaches to the point of 23 to 25 cc per 100 gram per minute, and the pH remains plateaued. And beneath this, the irreversible damage starts happening. The histological slide of this region of the brain shows about 70 to 80% damage of the neurons. So this area between the 23 to 12 cc of 100 gram per minute cerebral blood flow was thought to be the critical blood flow of the penumbra region, and beneath this there will be a core infarct or irreversible damage of the brain. Now let's talk about what happens in the penumbra, the molecular and the cellular mechanisms, and the ischemic infarct. We'll be talking this in details because I'll be talking about the potential therapeutic targets for the neuroprotection. This is a basic module, a neuronal cascade for the cellular death after the stroke. As you can see in this basic module, after the reduction in the cerebral blood flow, there will be the depletion in the energy stores, leading towards the anaerobic oxidations, acidosis, and the pump failure in the cellular membranes. It leads towards the accumulation of the glutamate in the synaptic cleft that further activates the NMDA and M5 receptors, leading towards the increased concentration of the calcium inside the neurons or inside the brain cells. This leads towards the activation of the increased nitric oxide production and thereby free radical oxygen species as well. That ultimately leads towards the irreversible damage of the brain. Likewise, when the reperfusion gets reestablished, then the inflammatory process, guided by the cytokines, further guides towards the damage of the neurons. This is the basic modules of the neuronal death after the ischemic stroke. Now I'll be talking in details about the multiple pathways through which this phenomenon occurs. This pathway is too complex, and I've tried to summarize it as much as possible. We just talked about the excitotoxic damage of the glutamate to the neurons, where after the pump failure and glutamate accumulation in the extracellular space, it will activate the AMPA and NMDA receptors. It is not just the influx of the sodium, but also the calcium and the water in the neurons that leads towards the cytotoxic edema. Down the hill, it will activate the proteases, lipases, nucleases, and calcium-dependent enzymes that leads towards the death of the neurons. This calcium influx is not just dependent upon the glutamate. There are some channels that are independent of the glutamate as well, like that of sodium and calcium exchangers, recently discovered ASIC1A receptors that leads towards the increased intracellular accumulation of the calcium. Likewise, another mechanism of the cellular death is oxidative and nitrosative stress. The major derivative of the reactive free oxygen is the NADPH oxidase. There will be the uncoupling of the oxidative phosphorylation in the mitochondria, leading towards the production of reactive oxygen species. The nitric oxide that has been abundantly produced after the activation of the glutamate on the AMPA receptors combines with the reactive oxygen species, producing the peroxynitrite, which is toxic towards the brain. Altogether, these toxic materials leads towards the accumulation or activation of the PARP gene and enzymes inside the neurons and astrocytes, leading towards a disruption of the pro-death and pro-survival pathway, leading towards apoptosis and necrosis. Likewise, the recent studies have shown the inflammation not only acts in the repair of after the stroke, but it acts early after the few hours after the onset of the stroke. The activated blood vessel walls, with the help of cytokines and chemokines, recruits the neutrophils and monocytes, leading towards the activation of the NF-κB-dependent inflammatory signaling pathway, leading towards a secondary infarct progression, which will further deteriorate the neurons. Recent studies has also shown and talked about the cortical spreading depolarization that happens after the activation of the NMDA and the AMPA receptors. Cortical spreading depolarization is a highly energy consuming process, leading towards a high ATP consumption, leading towards the further ATP depletions and the death of the neurons. After these multiple mechanisms, the cell is destined to die, and it chooses a pathway of either apoptosis or the necrosis. We'll be talking about the apoptosis and necrosis in brief, thus that we'll know what will be the therapeutic targets for the neuroprotections in the futures. As we can see in this module, apoptosis, cytokine C is been treated from the mitochondria that leads towards the activation of the caspase system and DNA fragmentation. Likewise, in the intrinsic pathway, major modulator of the apoptosis is the apoptosis inducing factor that will be produced with the help of heat shock protein 17 and PARP1 gene or protein activations that leads towards the DNA fragmentation. Likewise, necrosis has been further studied and has been now thought to be a well-programmed cellular death rather than a disorganized or unplanned cellular death. The major regulator of the necrosis process is the TNF-dependent pathway and the RIP1/3 kinases protein that will destine the cellular death by the process of the necrosis. These are the molecular and the cellular mechanisms in the stroke that happens in the penumbra and the ischemic core. The predominant process that happens in the penumbra has been thought to be the apoptosis. But these things we cannot see from the eyes. In the practical world, to treat the patient, we need to see the penumbra and the ischemic core to guide the treatment. So how to identify the penumbra? Penumbra or the perfusion scan can be used to identify the penumbra, like that of PET scan, SPECT scan, dynamic MRI perfusion, and CT perfusion scans. However, time is brain. We need some measures that is very fast and reliable. The ideal imaging tool is a Quest, but so far we have the CT perfusion that has been widely used all around the world because it is fast and easily accessible to detect the penumbra. Among the CTP post-processing software, Rapid software has been widely used in the major clinical trials. The CTP uses the same modules that we have discussed earlier, the cerebral blood flow and cerebral blood volume parameters, in order to map the perfusion area and core area. The 4 parameters that it uses is the cerebral blood flow, cerebral blood volume, time to peak concentration, and mean transit time. So how accurate is the CTP? Could it estimate the ischemic penumbra and the core accurately to guide the treatment? Or does it overestimate the ischemic core or the penumbra and exclude the patient from the critical or life-saving treatment? For this reason, we have done a study in our hospital as well. Before that, I want to discuss the basics of the CTP. As we can see in this figure, the red area has been mapped as the irreversibly damaged area of the CTP, which shows less than 30% of the blood flow. The green area has been mapped as a hypoperfused area where the Tmax is greater than 6 seconds. And the difference between these two areas is penumbra. That's how the CTP maps the ischemic core and penumbra and gives a mismatch ratio. But we have to know that this is just a gross estimation. It's a snapshot of the cerebral dynamics inside the brain. It does not assess the actual infarcted brain tissue. There are a lot of limitations in the CTP related to the heart failure, cardiac arrhythmia, motion artifact, carotid stenosis, truncation artifact that happens if we get the CTP very quickly, less than 40 seconds. So the accuracy of the CTP is in question. As I mentioned before, we did a study to estimate the accuracy of the CTP after the large vessel occlusion in our university. It was a retrospective analysis done from 2017 to 2019. We compared the accuracy of the CTP estimated core volume with a DWI infarct volume. We could not access for the penumbra because of the limitation of the imaging modalities. But we assumed if the CTP is estimating the core volume accurately, then it might map the perfusion scans and penumbra accurately as well. We included the patient who had the anterior circulation mechanical thrombectomy with a TK2B and 3 reperfusion, who got the baseline CTP and follow-up MRI after the mechanical thrombectomy. The patients were being dichotomized between less than 3 hours and greater than 3 hours from the symptom onset. The CTP core volume was estimated by the Rapid software automatically. The DWI core volume was manually calculated by using the volumetric formula of ABC by 2. Then we used certain terminologies, volumetric differences, and core volume overestimation based upon the difference between the volume of CTP and the DWI. We also used the parameter of large CTP core volume as greater than 50 ml. As we can see in this chart, the patients who got the CTP from the symptom onset less than 3 hours were 27, and greater than 3 hours were 34. These two groups were pretty identical based upon the median baseline NIH, based upon the CTP to MRI time, based upon the CTP to groin puncture time. Despite of the similarity between these two groups in the basic characteristics and timing, we can see the volumetric difference is only 0.1 in the group who got the CTP less than 3 hours. That means CTP overestimated the core volume. Almost 11 patients out of 27 has an overestimation of the core volume. Let's look towards the visual impression of our study. As we can see in this chart, from the symptom onset, less than 3 hours, the first thing when we got the CTP, the core volume in 40% of the patients were overestimated. After the reperfusion, DWI infarct volume was smaller. So it was clearly overestimating the core volume in less than 3 hours. And the patient where the core volume was larger than 50 cc in the CTP with a favorable aspect score had a good functional outcome. We can see over here 75% did have a very good functional outcome. But the patient who got the CTP greater than 3 hours from the symptom onset, it had a volumetric agreement with the stroke phenomena. Initial CTP was smaller, and final DWI infarct volume from the MRI was larger. And this is the natural progression of the stroke as per the time and as per the reperfusion status. And all the patients who had a core volume greater than 50 cc had a poor functional outcome, 100 out of 100. So we concluded that CTP overestimates the core volume if taken less than 3 hours from the symptom onset, and it does not predict the functional outcome of the patient. But it has a volumetric agreement after the 3 hours and is predicting the functional outcome of the patients as well. So, which is the best imaging modules in today's practice? I'll vote for CT perfusion because it is cost effective, it is fast, it is easily accessible, there is no metal screen that has been needed, it can be coupled with the CT and CTA at the same time and saving a time. There are limitations with MR perfusion scans. It is expensive, time consuming. A lot of constraints happens when there is a metal or unidentified pacemakers. So as a stroke is time and brain is time, CT perfusion in today's practice is ideal measures in order to map the penumbra. Now we have discussed about the mechanisms of penumbra and ideal imaging in order to detect the penumbra. Now how to save this ischemic penumbra? Reperfusion. Reperfusion has been the standard treatment to save the penumbra. It was December 14, 1995 when the NEJM published a paper of tissue plasminogen activator for acute ischemic stroke. That's when the Place came into the action. It increased or improved the modified ranking scale of the patient at 90 days who received the treatment. There was some hemorrhagic complications after the use of the Place, but the benefit outweighed the risk. FDA approved the TPA within 3 hours window. There was a CAS-3 trial done in Europe that extended the window to 4.5 hours with the selected patients. And now the AHA and the ESC, European Stroke Councils, approved the TPA for 4.5 hours on the selected patients. Very simple to use, just a CAT scan of the head, non-contrasted. But it has a major limitation, narrow time windows. And it has stayed as a mainstay of treatment for 2 decades from 1995 to 2015. 2015, there is the advent of endovascular therapy. It used the advanced imaging modules, CTP, MR perfusion, more so often the CTP, in order to map the ischemic penumbra, core volume, mismatch ratio, and selecting the patient that will get benefit after the clot retrieval. As we can see in this forest plot, after the meta-analysis of the 5 major trials, Mr. Clean, ESCAPE, Riwaj, SWIFT Prime, and Extend 1A, the MRS at the 90 days has significant benefit and favored the intervention. Based upon the age, based upon who received the TPA or not, and based upon the NIH score as well. And it standardized the treatment of endovascular therapy until 6 hours. That was until 2018, where the 2 groundbreaking trials, Dawn and Diffuse trials, were published. It extended the window up to 24 hours to the selected patients. The imaging parameter that was used was the CTP and the mismatch ratio. The number needed to treat was 2.6 for reduction of 1 point on MRS at 90 days. After all these studies, they formulated the CTP target profile for mechanical thrombectomy. the ratio of hypoperfused tissue to the ischemic core to be greater than 1.8 and others. And now the window has extended up to 24 hours for large vessel occlusions. Is that it? Or is there further treatment for the acute stroke or the management of the acute stroke? Endovascular therapy can only be given to the comprehensive stroke center. It is limited in the US. It is limited in the whole world. So I think the chemical thrombolysis will still stay as the main treatment for the acute stroke management. So we should look towards extending the window of the chemical thrombolysis. So we'll talk about the few studies that have extended the window of the TPA. Published in 2019, the Extend investigators in the NEJM thrombolysis guided by the perfusion imaging up to 9 hours from the stroke onset. It was a multicenter trial, enrolling the patient in the two groups, Altiplace and the placebo group. Total patients enrolled were 225. Standard dose of the Altiplace was being given. The patients had a symptom onset between 4.5 to 9 hours, or wake up stroke with the noticeable symptoms within 4.5 hours. They used the CTP parameters in order to guide the treatment with the mismatch ratio a little bit changed, greater than 1.2, and the core volume less than 70. You can see in this figure the primary outcome was the MRS at 90 days. And despite of the small sample size, they were nearly statistically significant. The primary outcome, or MRS, at 90 days were better in the Altiplace group. Likewise, there is the increased symptomatic intracranial hemorrhage in the Altiplace group too. Again, nearly statistically significant. But they will achieve this if we increase the sample size, I think. The same study, as we can see over here, the patients with a perfusion mismatch who got the Altiplace in the extended window, which are the target age group that will benefit. The age group greater than 75, we can see this is forest plot depicting the MRS at 90 days. This is the area which favors the Altiplace in the extended window period of time. Greater than 75, we can see the benefit, but greater than 80 or octogenarians, we see a lesser benefit compared to less than 80. So the upper limit for the age of this study were between 75 to 80. Likewise, NIH higher than 10 were less benefited than the NIH less than 10. We can see the maximum benefit were achievable within the known window of 4.5 to 6 hours compared to greater than 6 or 9 hours, or even a wake-up stroke. As we can see in the figure number B, the number of the patients who were able to achieve the modified ranking scale of 0 to 1 at 90 days were much larger on the Altiplace group. So this study concluded the favorable outcome of the Altiplace, guided by the CTP imaging techniques with the guided parameters, had a favorable outcome with Altiplace at 90 days. However, there were more symptomatic intracranial hemorrhage. This trial was being stopped due to the Epicos. There was another study, the Wakeups trial, that used the MRI-guided thrombolysis for unknown time of onset. The total patient number were 503, divided into the two groups, Altiplace and placebo group, with almost identical number of the patients. Their median last known normal from the symptom onset was 10.3 hours. As we can see, the primary outcome was MRS 0 to 1 at 90 days. And it was statistically significantly favored the Altiplace group on this extended window period of time. They used the diffusion, DWI, and FLAIR mismatch criteria in order to give the TPA. Likewise, the number of the patient who achieved the MRS 0 to 1 in this figure we can see were significantly higher in the Altiplace group. So this study also favored the Altiplace in the extended time window or with a patient that fulfills the criteria of the DWI-FLAIR mismatch. We'll talk about the meta-analysis and some systemic review that has been done about the use of the TPA in extended window period of time. We'll be talking about the Extend ECAS-4 and EPIFET trial. The symptom of onset was greater than 4.5 hours. All of these trials have used either CTP or MRI perfusion scans. The total number of the patients were 440 divided with the TPA group and the placebo group. And we can see again the number of the patients who were able to achieve the MRS of 0 to 1 at 90 days were significantly higher in the Altiplace group. And this is a pooled meta-analysis from all the studies in the extended window period of time. So the conclusion is, with the proper imaging modalities and target patients can still benefit from the TPA in the extended window period of time. But there would be a risk of increased intraparenchymal hemorrhage. All of these trials has been shown a favorable outcome with the Altiplace in extended window, as shown in the forest plot with the MRS at 90 days. Either by the age profile, either by the NIS profile, or either by the unknown time of the symptom onset, it favored the Altiplace group. So this might be the future in the acute stroke management. What about other medication? Is there any other medications apart from the Altiplace, which is better than Altiplace? We'll be talking about the Inactive Place. Inactive Place is genetically engineered from mutant TPA. It has a higher affinity to bind to the fibrin. It increases the conversion of plasminogen to plasmin. It has a greater resistance to inactivation of plasminogen activator inhibitor 1, leading towards the less disruptive mechanism in the hemostasis that has been theorized to cause the less symptomatic intracranial hemorrhage. It has a longer plasma half-life and it can be given with a single IV bolus. This Inactive Place we'll be studying about the ongoing trial of the Inactive Place in the acute stroke treatment. This is the review of the completed trial so far on the Inactive Place. As you can see in this table, in 2005, Haley, first of all, did a study on the Inactive Place, a safety profile on the Inactive Place dosing. It shows 0.1, 0.2, 0.4, and 0.5 milligram per kg of Inactive Place dosing. And he found like 0.1 equal efficacy and 0.5 and 0.4 dosing might have the increased risk of the hemorrhagic bleed. Likewise, the Australian Inactive Place trial groups, Parsons et al., published in 2012, utilized 75 patients. And it was a superiority trial designed for the large vessel occlusion and the use of the Inactive Place. The time window was 6 hours. And both of the dosing, 0.1 and 0.25, has shown the superiority versus Altiplace. And among these two dosing, 0.25 was superior than the 0.1. Likewise, the test trial studied about the fibrinolytic actions of the Inactive Place compared with the Altiplace, and it has shown the less disruptive mechanism of the Inactive Place in the fibrinolytic system, leading towards the lesser symptomatic intracranial hemorrhage. Tempo 1 trial was done for the large vessel occlusion and the use of Inactive Place, extending the window to 12 hours, and they have found 0.25 milligram per kg of Inactive Place use has a better recanalization. After 2007, NORTEST and Extend 1/8 Inactive Place trial has been completed. NORTEST tried the Inactive Place on acute ischemic stroke without large vessel occlusion within 4.5 hours of window, and they have found the safety and efficacy of Inactive Place is comparable towards the Altiplace. But there were limitations on this study, leading with the use of low NIH poor patients, stroke mimics. All of those patients were included in this study. Extend 1A trial that has been completed was the use of the Inactive Place, and the primary outcome was to check the recanalization status after the large vessel occlusion. Larger amount of the patient were recanalized by the use of Inactive Place. But these all trials use a different kind of the imaging parameters. As you can see over here, Nortest and Haley's et al., the study done in Australia, only used the CT head parameter, whereas the study that included a large vessel occlusion like that of Tempo 1 and Extend 1 at Inactive Place trial used additional CTA and CTP parameters as well. But overall, the recanalization rate with Inactive Place was better in compared towards the Altiplace in the Extend 1A trial and all the pooled analysis from the ATTEST and Australian TNK trials. Likewise, the primary outcome modified ranking scale at 90 days were better with the Inactive Place, who didn't got any kind of thrombectomy, and even one who got the thrombectomy in the Extend 1A Inactive Place trial. So the conclusion is the functional outcome among all these patients with a vessel occlusion or the mismatch were generally very good in both active and comparator group. The group with target mismatch on the CT perfusion has improved outcome with Inactive Place versus Altiplace. And it is a promise in the future, promising drug in the future stroke management. But there were a lot of variability on the previous studies regarding the imaging parameters. So now, the ongoing trials, ATTEST-2, TEST-2, Extend 1 Inactive Place 2 trial, TWIST and Tempo 2 trials are being designed by using the imaging defined therapeutic targets. They have used large samples on their study. They have used the CTP mismatch ratio parameters to guide their treatment. And they have been well-designed trials, either superiority or non-inferiority trials. Some trials are checking the recanalization status, and some trials are checking its superiority compared towards the placebo. And I think with these all trials verification, Inactive Place has a promising future in the acute stroke treatment. Talking about the Inactive Place and the basilar artery occlusion as well. Published in Neurology recently in 2021 March, is a very fresh data. The basilar artery occlusion patients who received the TPA and or Altiplace and the Inactive Place, the patients were being pulled from the Batman registry and the Extend 1A trial registry. And they have found there was a substantial reperfusion of the basilar artery occlusion and the Inactive Place group, with a significant p-value too. There were lesser hemorrhagic complications compared to the Altiplace group as well. So Inactive Place do have its future in the basilar artery occlusion as well. Talk more about the basilar artery occlusion. Basilar arterial occlusions are excluded from the major trials. This is one of the most or the worst nightmares of our vascular neurologists, leading towards the morbidity and high morbidity and mortality. The best trial has shown the endovascular treatment and the intraarterial thrombolysis almost has equal efficacy in the patient outcome. But the recanalization status is better with the intraarterial thrombolysis. Previous study has used the posterior circulation aspect score that has been determined from the CTA source image, and this could not predict the penumbra. As we can see over here how the posterior circulation aspect score can be calculated is by giving the same 10 points number towards the infratentorial structures and the occipital lobe and thalamus. The pons carries 2 points, the midbrains carries 2 points, 1 point each towards the cerebral hemisphere, 1 point each towards the occipital lobe, and 1 point each towards the thalamus. and will deduce 1 point each as we see the hypodensity in that region. But as I said, this module does not predict the penumbra. This module was not guiding towards the treatment. So we need a better imaging parameters that can detect the penumbra and the core volume. Recently published paper in International Journal of Stroke in 2019 did a study with the CT perfusion for the posterior circulation stroke, especially vertebro-basilar artery occlusion stroke. 60 patients who had been enrolled who got the CT perfusion, whole brain CT perfusion, and they have found the cerebral blood volume is the parameters that detects the core volume and the penumbra with greater accuracy, with a significant p-value as well. And if we map the posterior circulation aspect score using the cerebral blood volume, then it can predict the patient functional outcome. The aspect score lesser than or equal to 8 were independently associated with a poor outcome. So combining these imaging parameters along with the Inactive Place or endovascular therapy can be the future for basilar artery occlusion treatment. As I said, the future is promising. Currently, only 3.2 to 5.2 patients receives the TPA in the US. We have to think about extending the window of TPA, or we have to think about the newer medication, Inactive Place, which has shown the promising results so far. If the TPA has a toxicity towards the blood-brain barrier leading towards a symptomatic intracranial hemorrhage, we have to think about the combination therapy with the TPA that will outcome that adverse effect of the TPA. We have to think about the better imaging modules for vertebro-basilar artery occlusions and the chemical thrombolysis or the mechanical thrombectomy for this life-threatening stroke. Likewise, we have to think more about reducing the time from the symptom onset to the acute treatment. Promising studies has been done for the mobile stroke unit. The last time Dr. Lu has presented the ground round on triaging the patient directly towards a comprehensive stroke center from the symptom onset. Likewise, direct triage of the patient towards the IR chute rather than the ED can be the future of the stroke world in reducing a time from symptom onset towards the acute treatment. Is reperfusion the only thing that we can use in the treatment of the acute stroke management? Probably not. We'll talk about some blood pressure management measures as well. The concept of collateral circulation is, it is a subsidiary network of the blood vessels that stabilizes the cerebral blood flow after the principal conduct fails. There are two sets of the collaterals. Primary set of collaterals that comes from the circle of the Willis. Secondary set of collaterals that comes from the external carotid artery and its branches. It can be detected by the multi-phase CT angiography. And the theory is that if we augment the blood flow through this collateral system, the dying brain cells might get additional blood and it can improve an outcome. But the clinical trials that has studied the augmentation of the mean arterial pressure by using the vasoconstrictive measures has not shown the promising result in the functional outcome. So what are we missing over here? Is the cerebral autoregulations. The cerebral autoregulations is the ability of the brain to maintain the stable cerebral blood flow despite the fluctuations in the mean arterial pressure that gets disrupted in the acute ischemic stroke. As you can see in the Mr. Clean trial has shown the U-shaped module of the outcome of the patient with the systolic blood pressure. Both low systolic blood pressure and high systolic blood pressure has a poor outcome. So what is an ideal blood pressure that we can set after endovascular therapy or after ischemic stroke so that they would have a good prognosis? The better way to manage the blood pressure is rather than targeting the mean arterial pressure, we have to talk more about the blood pressure variability. We did a meta-analysis on the blood pressure variability and the clinical outcome. Meta-analysis of 11 studies from 2018 to 2020, utilizing the primary outcome measures, majorly the functional independence at 90 days, using the parameters that actually defines the blood pressure variability, like standard deviation, coefficient of variation, successive variation, and variation independent of the mean and outcomes. We can see the MRS at the 90 days over here. With the fluctuation, with these parameters, shows increased blood pressure variability and a poor outcome on the patients. So our study concluded that blood pressure variability is independently associated with a poor functional outcome. And blood pressure variability is better explained by using the parameters like standard deviation and coefficient of variations. So the individualized blood pressure target should be thought about. Likewise, dynamic blood pressure target should be talked about. The blood pressure goal before thrombectomy and after thrombectomy changes. It's dynamic. And rather than a blood pressure goal of one-size-fits-all approach, we have to think about personalized blood pressure goals depending upon the blood pressure variability and reducing the blood pressure variability. And that can save the ischemic penumbra. Metabolic management, I will be talking about hyperglycemia. Hyperglycemia has a direct toxic effect towards the blood-brain barrier, producing large amount of lactic acid and the free radicals. As we can see in this flow diagram, how the increased glucose will increase the anaerobic metabolism in an ischemic environment, leading to lactic acidosis and neurotoxic damage. We have done a study in our hospital, mentored by Dr. Haboubi, about the outcome of mechanical thrombectomy among diabetic and non-diabetic patients. It was a retrospective study among the large vessel occlusion who got the mechanical thrombectomy. As we can see over here, the diabetic group, the number of the people who achieved the MRS of 0 to 1 at the point of discharge were significantly smaller than the non-diabetic group. The diabetic group had a poor functional outcome that was been defined by the MRS greater than 2. Further, our study also showed there is no difference between the left and the right MCA stroke outcome if the patient is diabetic. There were a lot of biases in our study regarding the sample size, excluding the age and the hypertension. We did not do the age adjustment and the hypertension, history of hypertension adjustment. But overall, we concluded the poor functional outcome in the diabetic patient compared to the non-diabetic patient, irrespective of the initial hyperglycemia. So the measures should be taken to control the blood glucose. The SIGN trial was been designed where they tried to aggressively check the blood glucose in the initial 12 hours from the symptom onset by using the IV insulin drip. But we can see over here in the MRI starting at 90 days, the standard treatment who received the sliding scale insulin and intensive group who received the IV insulin restricting blood glucose between 80 and 130 did not have significant difference among these two groups. In fact, the group who were receiving the aggressive glucose treatment had a poor outcome at 90 days. So currently, sliding scale insulin is a standard treatment to check the hyperglycemia within the first 24 hours of the symptom onset. Likewise, finally, I'll be talking about the neuroprotections, all the mechanisms that I talked earlier. What are the possible therapeutic targets? It can be the NMDA alpha receptor blockers. It can be the ASIC1A blockers, NADPH oxidase blockers, likewise NFKB dependent blockers, likewise apoptosis-inducing factor blockers and RIP kinase blockers. So there are some therapeutic targets theoretically, but more than 100 trials have failed in a couple of decades in the past. They have used the sodium channel blockers, calcium channel blockers, the glutamate blockers, NMDA blockers, but all of these trials has not shown a promising effect in the acute stroke management. Why is that? What are we missing over here? Let's talk about the neurovascular unit. Neurovascular unit comprises of the neurons, the blood vessels, astrocytes, and perivascular cells. This is a tightly regulated microenvironment that regulates the cerebral blood flow, blood-brain barrier permeability, immune tracking, neurotropic function. It's not just saving the neurons, it is saving the neurovascular unit by itself, which will crosstalk with the neurons for its survival. So the therapeutic target should be targeted towards the neurovascular unit rather than the neurons itself. Is there a flaws in the animal models? Does the mice actually mimic the human brain? Is that because of the heterogeneity of the stroke patients, varied collateral status, varied cerebral autoregulation compared towards the mice models? Is that all these neuroprotectant trials has been done in the controlled environment in the labs where there is no blood pressure variability, no fluctuation in the body temperatures, or no fluctuation in the metabolic derangement? Is that because of the drug delivery was not adequate? Side effect profile of the drugs was not better studied. These might be the possible reasons why all those trials were been failing and not showing a possible better outcome. For this reason, the NIH has came up with the Stroke Preclinical Assessment Network, or called as SPAM. This network has been designed to tailor the future neuroprotectant trials in a better way so that a better result or promising result can be obtained. Its objective is to test the additional benefit of the reperfusion in an experimental controlled setting. The 6 leading academic sites that has already an experience on this study will be doing the study on parallel among the one who is conducting the studies. And there will be a coordination among this group so that the failure of the future neuroprotectant trial can be prevented. Overall vision of the SPAN is to accelerate the identification of the most promising neuroprotective drug in the treatment of the acute stroke. Thereby, I conclude my grand round of talking about this and reinforcing about these modules of the reperfusion, neuroprotection, blood pressure management, and the metabolic management, which all are required and is the future of the acute stroke management. Thank you very much. I'm open for the questions.
Thank you, Riwaj. That was very good, very comprehensive, and very, very well presented.
Thank you, Dr. Palani.
Thank you, Riwaj. Well covered. Well done. We like that.
Get them more. Don't hear any questions, so I'll be stopping my presentation hereby. Thank you, everyone, for listening to the presentation.
Thank you. Great job.